Hello, everyone. Welcome you all to this interesting talk today on hot topics in medicine, which we have aimed for all the A level students who will be doing the interviews later this year and early next year. My name is Dr. Anand, and I'm a consultant psychiatrist who works in the NHS. I've been interested in teaching and coaching A level students, and we have done it over the last few years. Some of you might have earlier attended the MMI interview session a few hours ago, and thank you for joining us today. You all have come a long way doing your UCAT exams, applying to the 4 universities, and waiting for your interviews. The whole purpose today is to help you to be more prepared when you attend the interviews. As you know, being a doctor must be a well-rounded person, and which is testing different capabilities, not only academic but also in other aspects. With that in mind, we have here 6 senior NHS clinicians who have volunteered their time despite their busy schedule during the week. So we are really, really deeply honored and privileged to have all speakers today, who are all leading figures in their respective fields. We are going to cover a varied topics which we hope will be helpful for your interviews or for general in knowledge in general. So if you have any questions, please post it whilst the speaker is speaking, so that we will try to address it either in the chat box or by the speaker itself. Speakers can't stay until the end of the session, which we hope to finish by 8:15. I know you've got a long week ahead, everyone. I'm also pleased to say that we will be releasing our Hot Topics book, which we will hope to send you in 10 days' time. So don't worry if you want to listen to all the speakers. We will be recording this session and sending you the YouTube link by next month. By next weekend. So with this, I would like to welcome you all again, and I would like to invite our first speaker, Professor Reggie Alexander. Professor Reggie Alexander is a consultant psychiatrist. He's my senior colleague working in the NHS and has been an inspiration to me, and I hope he inspires you over the next 10 minutes of his brief talk. Professor Alexander has done numerous work in the psychiatry of intellectual disabilities and has published numerous publications. He works in the NHS as well as very active in the Royal College of Psychiatrists, and we hope he will become the president of our college when next year. He's going to share with you his insights and some inspirational information. Over to you, Reggie.
Thank you very much, Izil. Let me try sharing my slides. I hope it works. These are always anxiety-provoking moments. Can you see that now? If someone can give me a thumbs up.
Yes.
Yeah, great. Okay. Let me do that. Yeah. So thank you very much, Izil, and good evening, everyone. It's such a pleasure to be here this evening and to talk to an audience of young people, not just ambitious, but also motivated to seek a career in medicine. So Ezel wanted me to set the scene by giving a general introduction to the National Health Service and then leave it to the other speakers today to pick up on the weightier themes. So let me start with a bit of a history lesson for you, medical student aspirants, starting in 1942. Many of you would know, particularly those who've done history as an optional subject, would know that 1942 is the midpoint of the Second World War. It is a time when this country doesn't quite know whether victory is in sight. On the one hand, France and much of Europe has fallen before the Nazi war machine, and things look bleak, the path of blood, sweat, and tears. On a more optimistic note, we also know that the Nazi war machine, which had started a war with Russia, hasn't yet conquered Moscow. And the United States, then a beacon of freedom and democracy, had entered the war on the side of the Allies. It is a tribute to the optimistic resilience and clear-headedness of this nation, that there was, even in the midst of all that ambiguity, there was still thought and consideration for the future. Thought about a future that would emphasize not just equality, but equity. A future that would reward the ordinary working men and women who contributed to victory. This is where we think of William Beveridge and the Beveridge Report. This is important because this was the basis that led to the establishment of the National Health Service. William Beveridge was an economist, a thinker, a philosopher, an academic, a director at the London School of Economics. He was tasked by the wartime coalition government to create this report that sets out a vision for the post-war future. The Beveridge Report, and some of you would know about this already, the Beveridge Report spoke about the 5 malevolent giants to be tackled on the pathway to reconstruction. And it is there on that slide: idleness, want, disease, ignorance, and squalor. Its proposed solution was quite radical. The state should have an active role in facing down these malevolent giants. The report proposed non-means tested benefits to all citizens on a range of issues, from maternity grants to children's allowances and disability benefits. It proposed the creation of a society which, in some ways, you were indeed the good neighbor, one that did not walk by on the other side. The creation of a universal health service, accessible and affordable for all, was part of that Beveridge vision. Fast forward to 1945, a country victorious in war and yet totally broken in its economy. That country would face a test of its soul to decide whether these noble aspirations of the Beveridge Report would withstand the reality test. The 1945 election campaign, as election campaigns are everywhere, was brutal, with the sitting Prime Minister warning of a socialist Gestapo state, and the then Labour Party committing to the vision and optimism of the Beveridge Report. The result was a spectacular landslide for Clement Attlee and his Labour Party. Ironically, William Beveridge himself, who had become a member of the Liberal Party in 1944 and gained a seat in Parliament, lost his seat in the 1945 election. The man whose vision shaped an age lost his own seat. Such are the vagaries of history. Soon after the 1945 election, efforts were underway to introduce the National Health Service. And you should know this. Aneurin Bevan, the son of a Welsh coal miner who left school at 14 and later worked in the mines himself, went on to become the youngest cabinet minister in the Clement Attlee government, as Secretary of State for Health. He was the architect of the National Health Service. The obstacles on that pathway came not just from opposition parties. It came from other quarters too. The BMA, the British Medical Association, was not just against, but overwhelmingly against the introduction of the NHS. And this was not all due to selfish interest, and it is this complexity that one needs to understand. At least some of that opposition may have been driven by a realistic fear that a state-run system where doctors would be employees of the state would seriously undermine professional independence and autonomy. There were concerns from patients too that their care could be decided not by their own agency, but by a bureaucrat on behalf of the state. Notwithstanding all this, by May 1948, the BMA had recommended that doctors should join the NHS. And on the 5th of July 1948, the NHS was launched. Mr. Bevan would remark later that this was achieved by stuffing the mouths of doctors with gold. So what is the basic structure of the NHS? At its very basic level, it means that every citizen in the country is registered with a general practitioner. That is primary care. Primary care is not just the first port of call, it is also a gatekeeper for access to secondary and tertiary care in hospitals or more specialist hospitals. All this is based on clinical need and not the capacity to pay. It is funded by central taxation and free at the point of delivery. The central feature of the system is that it completely and utterly removes the fear of bankruptcy when faced with ill health, an interesting contrast with other healthcare systems in the so-called civilized world. The NHS's genius has been its capacity to evolve over time. Just a few years from its inception, there was a move away from everything being free at the point of delivery. Dental and optician charges were introduced in 1951, barely 3 years after the NHS was launched. And this was a response to the financial squeeze due to the Korean War. The NHS's creator, Aneurin Bevan, resigned from the government in protest. And then in the early 1990s, there was an introduction of the purchaser-provider split. And this means that while everything is funded by central government, by central taxation, one branch of government, or one branch of government funded agencies would be funding the purchasing aspect, while another branch, the provider hospitals, and this is how the NHS Trust came into being, would do the providing bit. The theory, of course, was that multiple providers would compete against each other and, contest for the most cost effective way of providing services. We can all have our views on how that turned out. And what has happened over the years, from the late 90s to over the next 20 or 30 years, is a fundamental difference from how the world was in the late 40s. There is an increased demand. There is an increase in the level of expectations, and there is an inevitable increase in the length of waiting lists. And to deal with this, and for those of you who are aspirants for medicine, it is very important that you understand that in a system where medical education is funded by the state, it is important for the state to consider the increased demand and the lengthening waiting lists. And their solution was the introduction of non-medical individuals as clinical practitioners and physician associates and physician assistants and so on. While this was intended with the best of intentions as a way of cutting waiting lists and meeting consumer demand, it has now led on to doctor unemployment and widespread dissatisfaction, not just among doctors, but also amongst the general public. And this is where you need to be aware of something that came out in October 2025, the Medical Training Review, what is billed as a Phase 1 diagnostic report. But at the risk of slightly depressing you, it says in 2023, over 3/4 of UK doctors completing Foundation Year 2 in England did not or could not progress directly into core training, the first rung of the postgraduate training process. The report concluded that what is needed is not incremental change in postgraduate medical training, but a fundamental rethink. And these are some of their suggestions. They said there should be a review of the ratio of new international medical graduates to those who are already in the NHS. A less rigid differentiation between training and service roles with more flexibility and more of a review of the rotational structure of training. More training places. I mean, this is an idea borrowed from places like Canada and Australia. More training places in more needy areas. And a widening of the training sites beyond the conventional NHS sites. Less bureaucracy for educators, less bureaucracy is a standard slogan for most things. And then bring in changes in line with the NHS 10-year plan. And I would encourage you to Google and be prepared for questions on the NHS 10-year plan. Review the recruitment structures with a better balance between local and central strategies. And finally, develop clinical academics. Develop clinical academics, and that is what I'm going to end my talk on. This goes back to the question of who is a doctor. There is a temptation to think that medicine is a collection of skills, and it is very clearly not. If medicine was a collection of skills, then people could go to a series of short training courses and become doctors. That is patently inaccurate and untrue. Medicine at its core is an academic specialty. It takes 10 to 15 years of sweat and swat and hard work to mold a medical student into a consultant or equivalent. It is a rigorous academic process based on core academia, but honed in the field of an apprentice model. And it is that process, that interpersonal and academic that forms the fundamental basis of an abiding trust between doctor and patient. And those of you aspiring for a career in this field needs to have a proper appreciation of that. Healthcare systems will come and go, governments will come and go, but that central principle of the relationship between doctor and patient and the fundamental basis of the academic roots of medicine will remain true. If you want a slightly informal but more detailed examination of that issue, do look at that blog of mine on my LinkedIn page. I've slightly overrun. Those are my contact details for those of you who wish to contact me. I'm very grateful for your attention, and I'll hand over back to Ezel.
Thank you very much, Professor Alexander. That was an excellent and inspiring speech. Especially, end of the day, my brain has lit up now, and then I'm sure everyone would have been greatly inspired. Just for others, Professor Alexander is a well-known speaker, and no wonder why he's considered as one of the future candidates to become the president of the Royal College of Psychiatrists. So thanks once again, Professor Alexander, for coming and sharing your Sunday evening with us. Thank you very much. We next move on to our next speaker, Dr. Senthil Kumar. We all know mental health is again a very important part of everyone's life, and also more so in the NHS. Dr. Senthil Kumar has been with us helping students at least at least I can think of 2018. He's a great teacher, very much interested in training, and here today we are going to hear him speak for the next 10 minutes on issues in mental health. Over to you, Senthil.
Thank you, Edil, for the kind introduction. Can you hear me?
Yes.
Okay. Okay, can you see the slides?
Yes.
Okay, thank you. My name is Dr. Mahalingam. I'm one of the consultants in substance misuse in Derby. I'm also the consultant for the East Midlands Gambling Harm Service. I think Ariel has done a disservice to me by making Professor Alexander to go first. It's very difficult to match the level of his presentation, but I'll try my best. So, like Professor Alexander have said, we have massive workforce shortages and the staff distress. In the recent research by the Royal College of Psychiatrists, it was found that 81% of psychiatrists, that is 1 in 8, experienced or witnessed a moral injury due to lack of resources. The Lancet defines moral injury, this is following the COVID pandemic, as feelings of guilt, shame, burnout, frustration, distress, or isolation due to lack of resource or due to lack of capacity, that as a doctor that we couldn't do what we are supposed to do to our patients. And also in 2024, our college found that 1 in 5 child and adolescent psychiatric consultant posts are vacant. But if you include those consultants who are employed as agency or locum, then it goes into 1 in 3. So there is a massive shortage in the CAMS specialty. BMA is saying that the workforce growth is not keeping in pace with the demand. and wants that the workforce is not big enough. And as I mentioned, the burnout and moral distress among the psychiatrists is on the increase. So why? Because 47% of the psychiatrists, when they were asked, they were saying that there is daily admission delays due to lack of either a local or a specialist capacity. What they mean by specialist capacity is like the specialist services like the perinatal psychiatry or child and adolescent psychiatry. You don't have local beds. It is a national bed, but also the local one will be with the community mental health team. And also over the last few decades, there has been a reduction of the mental health bed numbers. This was done with a good view because what they wanted is they wanted all the service, like Professor Alexander said, they want all the service to be provided in the community rather than in the hospital. Therefore, they reduced the bed numbers and then they increased the community provision. But what happened is the demand kept on rising, but the resource did not match with it. So we ended up in a very difficult scenario where the mental health bed numbers are low. The patients have been waiting long for admission into a psychiatric unit. This can be either in the community or in the A&E, because they can get admitted two ways. One is they'll be seen by the community mental health team, and then either they'll be referred to the crisis team where they will make a decision to admit, or for patients who are refusing to get admitted and if they are at high risk, they will undergo a process called mental health act assessment. I've come across some of my patients when I've done a mental health assessment in the middle of the night. They've been waiting for a day or two because of lack of beds. The RC Psych did a research for these two data points between February and April 2024 and 2025. There has been 22% increase in the inappropriate out-of-area placement, which has its own issue. So the community care has been expanding, don't get us wrong, but it has been uneven and under-resourced. And also, the services have been fragmented into functional teams like the inpatient team, community team, specialist like substance misuse team, perinatal, rehab. So this can have hindered into continuity and therapeutic relationships. For example, if a patient is seen in the community mental health team, then they'll be referred to the crisis team. And the crisis team will then, each has its own consultant. Then it will be admitted into an inpatient unit. And if they can't manage in the local inpatient unit, then they may be referred to an out of area. So within a span of 1 or 2 weeks, the patient may be seeing multiple staff, multiple consultants. That has an impact on the therapeutic relationship, because psychiatry, we mainly work with the therapeutic relationships and the rapport we have with the patient. Why this has been happening is mainly due to the funding, commissioning, and the system design challenges. Our president, Dr. Lade Smith, mentioned earlier this year that 20% of English disease burden is due to mental illness, but we are expected to receive only 9% of the health funding. And therefore, it shows the gravity of the situation. This leads on to lack of funds across different trusts, which can lead on to lack of staffing, lack of infrastructure, which eventually can lead on to workforce gap. This is not just consultancy, it is consultant psychiatrists, junior doctors, nurses, occupational therapists, social workers, etc., etc. And due to lack of funding, sometimes it also doesn't help with frequent reorganizations of the service. And also, that, like I mentioned, there is more reliance on out-of-area placements, which has an impact on the therapeutic relationship with the patient. So there has been a geographical variation in the workforce and access. According to BMA, Midlands and London have the worst consultant psychiatric vacancy. But amongst the 4 regions in our country, Northern Ireland has the worst psychiatric vacancy, and there is a major funding gap. Like, they were allocated 15.5 million. And what they need is actually 76.57 million, which is almost, they only get 20% of the funding that's required for 100% service. So there was a recent report also where in the end of September 2024, almost 352,000 under 18 has been waiting for the first contact with the NHS-led mental health services. And amongst these 350,000, almost 1 in 10 have been waiting for more than 2 years, and which is not acceptable. And also amongst this cohort, the ethnic minorities and people living in rural areas and low-income groups have worse outcome amongst the psychiatry patients. There was also a report by the Mind recently this year, where 14% of the public report a fear of someone with poor mental health living nearby their home or house, which has an impact on the stigma, which is rising as well. So what are the underlying drivers? Like I mentioned, the demand is constantly increasing and the resources constantly going down. So therefore, the demand and the resource are not meeting with each other. And of course, because of the funding issue, the workforce recruitment is an issue. And also, a lot of, as you must have seen in the news, a lot of doctors, senior doctors are retiring from psychiatry, from general practice, and from various other specialty fields. And also the chronic underinvestment has an impact on the mental health infrastructure, whether it's building to ambulance to various other infrastructure. So the funding has increased in recent years, don't get me wrong, but the funding is not matching the demand that is needed to deliver a service. So the services are also sometimes fragmented and they are target-driven services. Therefore, like I mentioned before, like community to crisis team to inpatient to out of area, therefore there is a interruption in the continuity of care, and also sometimes it can have an impact on the quality of services provided. But also some services will have a narrow access criteria. Therefore, patients with severe or complex management issues or patients with dual diagnosis. What I mean by dual diagnosis is patient with a mental health issue along with a substance misuse. Sometimes they have issues accessing the right service at the right time. So what are the consequences? Because of all these issues, there is a delayed access to the treatment, and also therefore it will lead on to suboptimal care. Therefore, the escalation of the risk is gradually increasing. It also includes suicide and parasuicide behaviors. Like I said, increasing out of area placements, which can lead to a lot of loss of support. Some of my patients have been placed 50-100 miles from Derby. Therefore, their friends or family cannot go and visit. Therefore, it can lead to loss of support network, which can lead to poorer outcomes. So the London School of Economics and Political Science and the Mental Health Foundation in February 2022 have published that the annual cost burden to UK economy due to mental health is 117 billion, which is a very big amount to consider. Of course, this is 3 years old. So due to lack of resource and funding, the burnout and attrition among psychiatrists and nurses is on the increase. Therefore, it's worsening the shortages. And also, the inequities and inequalities are widening by region, age, or social group, like Northern Ireland has been the worst affected. So, some other way forward would be having a ring-fenced mental health funding, which is actually aligned to actual demand. And like Professor Alexander said, we need to expand the psychiatric training, and also the recruitment issues needs to be under. Some of the doctors who passed the medical school last year had issues with finding a foundation year placement. So this needs to be addressed. And also we need to look at retaining these doctors. Therefore, we don't end up in a workforce shortage. We have to invest in community-based proactive mental health interventions. Therefore, we are proactive rather than reactive. There should be a promotion of continuity of care and therapeutic relationships within the community. And how we do that is by addressing the geographic, age, and ethnic inequalities with targeted investment. Like the area of deprivation needs the greatest need, therefore needs greatest investment. We also need to address in reducing the stigma and strengthen the social support and other prevention measures. And therefore, we need a system design which is patient-centered with holistic care. And I'm on my last slide here. So, in short, the UK psychiatry faces a systemic crisis where the demand outstrips the capacity, chronic underfunding, fragmentation of services, equity and equality gaps across all 4 regions of the country with ages and social groups. There needs to be an urgent need for funding reform, workforce expansion, and community focus. And without decisive action, these inequities and mental health burden will deepen. Before I finish, 30 more seconds, it's not all doom and gloom. Like Errol, have been here working in NHS for 25 years, and I still love my job. And it's frustrating. I can't do what I want to do, what I need to do, but I will do what I can do with the best of my ability. So all future colleagues who are here, don't think that it's all doom and gloom. It's not doom and gloom. I will stop now. Thank you.
Thank you, Dr. Senthil Kumar, for sharing the issues in mental health. But as you rightly said, it is a very rewarding field. And generally, life as a doctor, you're helping others and it's satisfying. Thank you very much. We will move on to our next speaker, Dr. Hema Kannappan. Dr. Hema is a consultant pediatrician and is a lead for pediatric gastroenterology at the University Hospital of Coventry and Warwickshire. She is also involved in other roles and actively involved in teaching and helping medical students. I believe she also won an award and was chosen one of the inspiring Indian women at an event at the British Parliament a few years ago. So over to you, Hema, and we look forward to listening to issues around in pediatrics.
Thank you so much, Eril, for that kind introduction, and thank you for the opportunity to speak. Following on to excellent talks, I hope to do justice to the 10 minutes that's been allocated to me. So I think one of the hot topics that will remain, hot topic forever, I think, is about immunizations. In clinic and also in MMI, there are a lot of patients, who have issues with immunizing their child, and that's exactly what I'm going to talk about today. So can I have the next slide, please, Priya? Thank you so much. So I think, the first thing we need to ask is the first and foremost question when they come and sit in clinic or, when you are in MMI and there is a hesitancy, the communication scenario could either be a patient refuses routine childhood vaccination, or the other MMI scenario that you might face is an ethical dilemma. Should vaccination be mandatory? And then, of course, there's always a public health scenario. For example, if you've all been following the news, we had outbreak of measles recently, and at that point there was a lot of discussion about whether vaccination needs to be made compulsory, whether they can attend A&E only if they've been vaccinated. So these discussions always ignite a lot of interest in the medical fraternity as well. So can I have the next slide, please? So when we approach somebody who's coming in with this, next slide, please, Priya. Thank you. So I think I've taken a 5-step approach here. So the first step is acknowledge their concerns. So I think, you have to acknowledge both verbally and also in your non-verbal, in your body language. So, you probably have a totally different view to what their view is. You might be angry, you might be frustrated, but you should avoid being judgmental or confrontational completely. And you have to start off by saying, it is true that you understand that deciding about their child's health is up to them, and it's completely natural for them to want to refuse. And most of the times, if you actually talk to these parents, there's an element of misinformation. There's a lot of fear because there's a lot of things that's posted online, and most of these people have documented, and it's very well recognized that they've done all their research, and they probably come to clinic with papers that you haven't read about. So the step 1 is acknowledging, and you have to start by recognizing the patient's concerns and their emotions. So we'll move on to step 2, which is the next slide, Priya, please. Thank you. So once you've acknowledged your concerns, what are you going to do? You're going to explore their concerns. So when you are exploring, it is absolutely vital that you use open-ended questions and non-threatening questions. So you have to ask them, say, for example, can you tell me what in particular worries you? Because one of the most common scenarios that I face in clinic as a pediatrician is most of them don't want to give MMR because they're worried that their child is going to get autism, because there was a lot of media hype about autism being associated with MMR vaccination. So once you've told you what their concern is, you then have to ask them, where did you hear about these concerns? Because you are actually taking time and you're taking their answers seriously, this will be able to, build a better rapport, and, they might be able to start trusting you. They might change their decision, but it's extremely important that you acknowledge, explore, and these 2 steps will help build a rapport. And please do remember that, what you say is important, but how you sit and your tone, everything is equally important. So that is step 2. So I'll move on to step 3, which is the next slide. Thank you, Priya, for the next slide. So I think, once you have done that, as I said, there's so much these days in artificial intelligence, and even before AI existed, Google was something, people used to go to. And yes, Google is good, but sometimes there's a lot of misinformation. So you have to correct that misinformation, and you should be in a position to be able to provide evidence based information. And once you've had this dialogue and discussion, they have presented their view, you have presented your view, then you have to emphasize the benefits. And when you emphasize benefits, it's not necessarily the individual benefits, but each of us have a responsibility towards community as well, because there's a lot of herd immunity in this. So it's not just them, they also need to think about the wider community. So these kind of things you'll have to be absolutely sure when you talk to them. And then always be honest in NHS, whether it's a mistake, whether it's a communication. Honesty is definitely the key thing that will take you, it's going to be very, very important, and you will actually see it in real practice as well. So it could be, the little side effects, which is going to be fever, soreness, child is going to be crying, or it could be bigger side effects, which is individually dependent on which vaccine they're going to choose. Because, COVID vaccine, I'm sure, you all saw a lot of protests on the roadside where, people were anti-vaccine. We had seen so many of these. Could be MMR, could be COVID, could be any other vaccine. So as a doctor, as a medic, it's extremely important to provide that evidence-based information. So once we have done this, we'll move on to step 4. Can I have step 4? Next slide, please, Priya. And okay, so they have given their information, you have given information. What is going to happen next? And you shouldn't push them to it. You shouldn't say, look, I've given you the information, I'm the right person, this is what you've got to do. No, it's ultimately their decision, but you have to make sure that it's based on accurate information. So that's extremely important. Most of the times, these people do not decide in clinic or in A&E or in a GP surgery. They would always want time, and they might need more information. So it's extremely important that you offer follow-up. And NHS and in MMI, you would never ever go wrong if you say, would you like some written information about this? And there's always leaflets readily available. You can either print out, or if there is one readily available, you can please take it and share the written information with them, because verbal information followed by written information is very, very important to close that loop of communication. And once you've done this, then we'll go on to step 5, which is going to be our last step. So which is, you have to have a very ethical and professional approach. So we have to respect parents' right to decide, but we also have to act in the child's best interest. And it's also extremely important that we have to prevent harm from disease or misinformation. And we have right and responsibility to look after community health through herd immunity. So I think these are the 5 points that I wanted to tell you all. So we'll have the next slide, and then I can summarize it for you and probably give you a little mnemonic to remember as well. So don't forget, this station tests about your empathy and also your communication skills, and it is very important not to get into a confrontational mode. You have to have the awareness of both individual health and public health perspectives. You also have to respect parental wishes while they try to prioritize your child's benefits. And you also have to understand the role of misinformation that's out there in the internet. And as I always say to all the students giving MMI, do not forget to give a proper introduction and a closing statement, because that's the key to gaining marks. And even if you do not know about the station, these things will really help you sail through. And the mnemonic which I was telling you is, the 5 steps are like the 5 vowels, A, E, I, O, U. So the first one is actually acknowledge. Second is E, which is explore. I and O will stand for information online. So there's a lot of misinformation online. So it is down to you to give them the evidence-based information. And finishing off with you, it's ultimately parents' choice to do what they want to do. So I think this is a very important station. And please, show verbal empathy, non-verbal empathy, and make sure you're not pushing them to it. Your job is to give them all the information. So that is what it is. So all the best if this station comes, and I hope this is going to be useful for you. Any questions, please?
Okay, thank you, Hema. That was a very precise and useful talk to everyone. And thanks for sharing all the information about issues in pediatrics. We need to move on. We need to keep up with the time. And thanks for volunteering your time and coming to speak to all the students.
Thank you.
Yeah. Next, we move on to our next speaker. Dr. Venkatesh is a consultant psychiatrist. He also has a master's degree in healthcare education. He's been a consultant for more than 13 years and training program director for the last 6 years. He is very much interested in the role of artificial intelligence. And as you all know, everywhere we hear about AI. Let us hear what AI has got in future in medicine. Over to you, Venkatesh.
Thank you, LL. Can you hear and see my screen?
Yes.
Okay, thank you. Thanks a lot for inviting me, and thanks a lot for inviting a human physician and not asking Alexa or Siri to present on this. It's a very straightforward agenda, so we'll talk a little bit about what AI is, why it should be used in NHS, what the benefits, challenges are, and some possible steps going forward. So what is AI? It is, as I'm sure a lot of you guys would know better than we all, it is a machine that exhibits intelligent behavior, and how it does that is by demonstrating higher functions such as learning, reasoning, and problem solving, so that those are things that have been considered human territory is now into the machine, so which then hopefully will improve efficiency. But this is where AI gets very exciting, because it doesn't just depend on one layer of information. It depends on multiple layers of information, which therefore enhances its potency considerably. And then particularly relevant for healthcare is one of the components of artificial intelligence is the so-called large language model, which excel in processing extensive textual data. So within healthcare, we hold both structured data and a lot of unstructured data. So those are the text. And one need not worry about doctors' handwriting, because obviously these days everything is recorded in electronic notes. So the potency of AI in healthcare is enormous. Why should we use it in the NHS? Because NHS is the largest publicly funded healthcare system, which means we have one of the biggest databases in the world. And we also have considerable AI capacity. And data is the new oil in this world of artificial intelligence, and AI is the combustion engine. So you can straight away see why AI is suited to NHS in particular. So what are the possible areas of use? I'm just going to touch on some key areas and try to remember this as obviously in medicine, we talk about prevention. So that's predictive analytics. We then talk about diagnosis, and we use radio diagnosis. And then we obviously treat with medicines. And then we do something for the patient, but you also have to do something for the doctors. So if you think in that order, predictive analytics is the ability to predict events, and artificial intelligence can do it at two levels. One at a population level, so it can predict infective outbreaks, and at an individual patient level, it can predict things like chronic kidney disease readmissions. But collecting data is an enormous challenge, which we'll come on to in a minute. So imaging, which is obviously the chest x-rays, scans, MRIs, and things like that. And here is a great example of how AI has helped this particular person identify their cancer a lot earlier, because it segregates normal from abnormal, and therefore speeds up the patient's care journey from weeks to days, which is again quite significant. And it also can help in drugs discovery. This particular aspect shows how much AI has influenced drug discovery, and it also means the journey from research to market is expedited as well. And in terms of precision medicine, so obviously these days, up until now, we have broad guidelines. So whether you're from Bangladesh or Barbados, the treatment for hypertension remains broadly similar. Whereas with the advent of AI and particularly our expanded knowledge about genomics, we can tailor treatments to suit to the person to the T, which then means you don't have to do any trial and error, and the patient can get care right first time. And it's not just for a patient care alone, it also considerably enhances physician clinicians efficiency. And there is this really exciting technology called ambient voice technology, which basically means all the consultations will be automatically translated into letters, thereby sparing the clinician from using time to dictate and type letters, which for clinicians here will understand exactly what it means. But it is not without challenges, and I've got a simple mnemonic for you guys to accept in terms understand and remember, and we will look into each of this in sequence. So the public trust in health AI is not actually brilliant. Only 37 people trust it, and there's a lot of concern, understandably, about privacy, data security, and transparency. And there's interestingly a lot of opposition from the public in terms of using AI for some key clinical areas of healthcare. And in terms of problems with data, so this is very important because we've got a lot of problems with data quality. So our data is not really good. So if your data is not good, then the product will also be not good. And all the data that we have exists in silos. So we need to find ways to get the data to talk to each other. And then the inconsistent data definition. So medicine in particular is very synonymous with using multiple synonyms, and we need to be able to find one way of giving data, or otherwise we're confusing these algorithms. Black box is essentially where these algorithms will give the diagnosis, but neither the patient nor the doctor knows how the diagnosis was arrived. So you can straight away understand how that could be challenging in any consultation. And AI also can increase existing inequalities. Now, Dr. Sendil talked about the inequalities. So basically, the data that we currently have might be representative of the majority and not the minority. And obviously, as you all know, UK is a multicultural, multi-ethnic population, and we may therefore inadvertently increase the inequality. And interestingly, AI does consume a lot of energy, which is very important in the way the world is going at the moment. So going forward, what are some of the options? I just wanted to remember these 2 points that I've highlighted, if not all 4. So any technology is useless on its own. It needs people and it needs strong processes behind the product. So that's what we call in digital transformation people, process, and product triad. And within people, obviously, you talk about doctors and patients. So all 3 things have to come together if we were to realize the potential behind AI. Now, there is a lot of challenges for training, because not only do we have new people like you guys coming into medicine, but we also have experienced clinicians like the speakers already in working in medicine. All of us need to be trained in AI. And not only that, we need to actually work with the IT guys in developing more appropriate algorithms. We cannot leave it to the AI people alone or the IT people alone. So that's a massive challenge, but needs to be overcome. How do we access it? So before we try and target clinical areas with all these risks involved, we can try these low-hanging fruits. So we are already using something called as Copilot to try and achieve a lot of admin-related efficiencies. And there is a huge amount of administrative burden for every NHS organization. And there's already a lot of promising evidence behind it. And also try to use it in education and training and learn from it, and before you apply it into clinical practice. And it's very important that we have the appropriate governance guardrails in terms of ensuring that AI is doing its benefits and whilst minimizing any inadvertent harm. So, for example, within the diagnostic imaging that we talked about, yes, it's really good at detecting cancers, but even the slightest change in the picture quality can take it completely to the opposite end. So, we do need to have the guardrails to ensure that such risky things do not happen, or at least minimized. So ultimately, in conclusion, it has tremendous potential, but it needs people and processes to come together if we were to fully realize its potential and turn it into performance. And thank you at that. I would highly recommend these books if you possibly can. Still in the world of AI, books do matter a lot. And these would give you some interesting insights in terms of turning this content into your own understanding and personalizing it to your situation. Thank you.
Okay, thank you, Dr. Venkatesh, for a very interesting talk to look at the future of AI. And some people are concerned we might not be having jobs as human, but you did reassure us that we'll be there. Okay, thank you very much for and volunteering your time on a Sunday evening. And we next move on to our next speaker. We have talked about various issues. Now we'll talk about issues in the general practice, which is where majority of you young students who will be trained to become a doctor and then become a primary care physician. Dr. Raji is a GP partner working in the NHS in Bradford. She is a GP trainer and has done several programs to promote health in the community. She's also the self-care lead in her GP practice, and today she'll be sharing a few minutes of her thoughts about current issues in the primary care. Over to you, Raji.
Thank you. Priya, can you share my slides, please? Hi, everybody. I think we've had a very remarkably useful and extensive talks from all my secondary care colleagues, and you've been hearing about the potential opportunities and the challenges that you might all be facing further into your career into medicine. And I'm here to give the GP perspective, the primary care perspective, and the crisis that GPs are facing at the moment, because it tends to be a very common recurring theme in MMI. Next slide, Priya. So what is the role of a general practitioner? I wanted to give a very brief overview of their role, because it is clearly important to understand what the GPs do on a day-to-day life. And they are primary care physicians. And as Dr. Reggie Alexander was listing, primary, secondary, and tertiary care of NHS structure, GPs are the cornerstone of NHS, and they are the primary care physicians, and everyone in UK should be registered with a GP practice. And GPs are responsible for the overall health of the population within their catchment area, which is devised by what is called as the NHS postcode, and within which the GPs then manage, treat, prescribe for both acute presentations and chronic conditions. And when you say acute presentations, it ranges from day-to-day common cough, cold symptoms to chest infections, and further on moving into chronic conditions such as high blood pressure, diabetes, and their attendant complications that will develop later on. They deal with both physical and mental health conditions. You've heard senior psychiatrists who are from secondary care talking about the mental health perspective, but the basic primary care physicians take care of physical and mental health conditions in the community. GPs arrange for investigations, refer patients to secondary care services, to the hospital colleagues, and once they are treated and discharged from the hospital, they follow up patients in the community, thereby overall providing the continuity of care. Next slide, Priya. So general practice, you can see the length, breadth, and the width of role a general practitioner plays, and general practice is considered to be the cornerstone of the NHS. However, GPs are currently under extreme public scrutiny and feel very much undervalued at the moment. And this is what the current data and the current statistics that are provided by patient bodies recurrently show. Next slide, please. And why is this? And what is the scale of this problem? Last year alone, NHS has lost over 600 odd GPs in England, meaning there is a further shortage of GPs. Up to around 4,000 GPs are at a shortage in overall in UK. 1 in 7 GP posts are currently vacant. And following this trend, if we further go into the next few years, 1 in 4 posts are likely to be vacant. And according to Health Watch, which is a patient body, 50% of patients complain that they are unable to book a GP appointment, and 70% of people in the UK lack confidence in their ability to get a GP appointment when they need one. So the sheer scale of the problem is immense. Next slide, please. And why is this shortage? Simply put, more doctors are leaving general practice both due to retirement, but also there is further on the number of doctors joining the specialty has been dwindling down. And there are various reasons for this. One of which is GPs are considered to be a 9-to-5 job, and thereby they don't work weekends, and hence they are paid less than our hospital colleagues. And however, but the demand of work in reality is GPs work longer hours, and thereby their demanding workload, they start at 8 in the morning, finish at 6. And because of that, the workforce has found that increasingly general practice has become a different beast than how it all started. And the 10-minute consultation per patient where patients are increasingly becoming highly complex and more and more challenging. And this has led to a significant negative downward spiral, and GPs are leaving in droves, moving over to greener patches. You constantly hear about GPs moving over to Canada and Australia. And the remaining GPs, and thereby are sustaining, seeing higher workload. And since 2015, the number of patients looked after by a GP has risen by 16%. And this makes GPs more likely to leave the profession. Next slide, please. So the consequences of the shortage, there has been also a very negative portrayal of GPs, and because of this, there's been a loss of professional satisfaction, work-related stress, and low morale. And consequently, there's been a significant struggle to recruit young doctors who want to come into the profession. And you hear from the patient as well that there is the 8 a.m. scramble. Say, for example, in the morning, on Monday morning, patients, when they start calling up GP practice to get an appointment, they are left in the queue for nearly 20 minutes to 30 minutes, and patients cannot access timely help and appropriate care for their health conditions. This leads to severe delays, and thereby certain serious conditions. If they are led to a delay in cancer, as you heard from Dr. Venkatesh Muthukrishnan, how important that it's important to, in a patient's journey, to have an early diagnosis and early detection. However, because of late detection, it leads to impact on patient prognosis and treatment. And there is also increase in health inequality. Patients in most deprived areas report that they have less primary care experiences. And also there has been the switch to remote consultations, and thereby you heard about how there's been a kind of low morale regarding remote consultations, AI, because some class of patients might find that it disadvantages them even more. And say, for example, elderly or patients with other learning difficulties, and they might find this a lot more challenging with remote consultations. And with all this, it leads to a spillover to A&E, increasing waiting times. So we heard about the long waiting times that NHS is facing already. So overall, you can see that what are the consequences and the downward spiral, and this has become unfortunately a vicious cycle. Next slide, please. And thereby potentials for GP shortage. And as Dr. Senthil Kumar said, it's not all doom and gloom. And we've all of us are senior colleagues who've worked in NHS for more than a couple of decades, and we are still very much passionate about our jobs, and we still want to make, and we know that NHS provides one of the best care that we can provide globally. And thereby it's about finding solutions. And you young doctors, when you're coming into the profession, you would be looking at options and solutions to deal with these problems. And one of that is clearly the funding is one of the most important reasons why there is a lot of lack of training, recruitment, and all that would make a big difference, if tremendously improve, if we are able to drive more funding into it. And GP workforce plans to increase the number of GPs, and thereby they're creating more GP trainees and GP training posts. And we are hoping that by 2031 we would have 6,000 more GPs who should be there, completed their training, and be able to offer their services. And there's also looking at other alternative health practitioners. Say, for example, we see a lot of advanced nurse practitioners, physician associates, and other physios and other healthcare practitioners joining in with GPs in their providing services in primary care level, and promoting health education and self-care awareness of public. And as Dr. Hema Kannappan was rightly pointing out, it is important to promote health education, vaccines, and thereby people are taking more responsibility for not only their own individual health, but their family, and also herd immunity. Vaccines provide herd immunity, thereby we prevent complications, prevent more illnesses, and thereby self-care awareness as well is very important public health awareness. Next slide, please. So it is important, you will come across in MMI various questions pertaining primary care, and it's quite important to understand the complexity and the challenges that are facing, not only generally about NHS, but also about the structure and how primary care and general practice day-to-day difficulties. So talk from a GP's perspective, but also be aware of the problems that are facing, and discuss about health inequalities, link it, because a lot of you would have had general practice experience, so link it with your work experience. When they ask about 8 a.m. scramble, how do you find that as a patient trying to contact? Link it with, I have seen this happening, and when I sat in with my GP reception, I saw that the number of calls that were coming through. So link it with your work experience and reflect on it, and thereby you should be able to kind of give an overall perspective. Next question. Next slide, please. So some of the questions that are likely to come in your MMI are, how can we address the lack of GPs in UK right now? How do patients perceive GPs? What does a GP do on a day-to-day life? What is the public image? How is the public image impacted by the GP shortage? How can we fix the shortage of GPs in UK? And not too long ago, Rishi Sunak was suggesting about charging for missed appointments. So what are the issues around it? And thereby you can talk about the ethical dilemma of charging. And then when Dr. Reggie Alexander was saying NHS is all about free and with no cost to the patient. So how do we balance that with lack of funding? And these are the challenges the next generation of you doctors coming in, incumbent doctors, will be facing. Who in the UK is most affected by GP shortage? So this is about health inequalities, and health inequalities tends to be a very often asked scenario in MMI. And thereby you can talk about all the pillars of ethics, and how do you understand, and what do you understand by health inequality, and how does it imply to general practice? Aside from GPs, who else may work in general practice? what does it mean to be a GP partner, and some of those kind of questions about the pros and cons of being a GP and a secondary care colleague. Would you choose to be a GP or would you choose to be a hospital doctor? Those kind of scenarios. So these are all some of the possible questions that you might find in MMI. But overall, good luck. And you guys coming into the profession, aspiring to be the next future generation of doctors. You've heard from some of the excellent speakers, and I'm inspired by them. So good luck with your journey forward.
Thank you very much, Raji, for sharing your insights on the current issues in the primary care. We now have our last but one speaker, Dr. Lata. Dr. Lata Korapati is an emergency medicine consultant working in the NHS. She has a keen interest in safeguarding vulnerable people and working with teams looking at helping homelessness and alcohol and substance misuse. She's going to talk about issues in the A&E. Over to you, Lata.
Hello, Adil, can you hear me?
Yes, I can hear and see you.
Okay. Okay, so I think you've had a long day. You all had a long day, and this is very apt because I'm coming in after Raji. So you heard about the problems in the general practice, and as Raji aptly said, that the spillover is to A&E. I'm sure you all know what A&E does. Any kind of emergencies we deal with, and it's not always the emergencies that present to and book into A&E. So we get a varied presentations. So I would classify, I'm going straight to the point, and if you get an MMI wherein the question is about the crowding in the A&E and how you can help with the crowding in A&E, I'm just going to tell you the points that will score you some brownie points, so that you can get some good marks there. So the A&E is divided. If you think of the flow of patients in the A&E, there will be an input, that is the number of patients booking into the A&E department, and the throughput is the amount of patients in the A&E department, and the output is how we send the patients out of A&E. Either we discharge them or get them to the wards or refer them to some clinics, and how we disperse those patients that are presenting and after having managed them. We have very little control over what we get as input. Anybody can book in. Any area people can come and book into any A&E. That is how the structure in A&E is. That's how nobody, in NHS, we can't refuse patients usually, especially if they come with emergencies. So we can improve the education of the general public about what A&E department is for, because people do come in with, say, though we have doctors in A&E, people do come in with dental problems, people come in with problems which can be dealt with by their own GP. They come with problems that can be dealt with by physiotherapists. So anybody and everybody can come into an A&E department. So better education of the people will help in controlling that. We have sometimes a better referral systems can also help with the amount of patients that are coming into A&E, because if the referral systems were good, then the GPs could directly refer patients to the specialities. They do not need to send them to A&E for us to send them to. So it is duplicating the work. Instead, if they are seen by somebody in the primary care and they think they need a hospital admission or they need a specialist opinion, they can be directly sent to the particular specialities rather than direct them through A&E. That can decrease the crowding in the A&E department. But what stops people from doing that is because, like Raji said, GPs have 10 minutes to sort a patient out. And in that 10 minutes, if they're picking a phone and trying to get to the concerned specialities, they probably will take more than 10 minutes just for getting in the person on the other side. So improving the communication systems, I think, is one of the ways we can, because all hospitals have usually very outdated communication systems. Better use of technology, better use of AI, better use of these things can improve the number of patients that are referred directly to the specialities, avoiding the duplication of work. How can we change the number of people in the A&E department? So, like I said earlier, not all patients are actually an emergency. We get a lot of patients who are not actual emergencies. And so such kind of patients can be sent to be sent back home with the idea to bring them back to the appropriate clinics or referral to a appropriate healthcare professional for the next day or a day or some other time in future. So that can be done, and we have all hospitals are nowadays moving towards all A&E departments are devising ways and means to direct patients to the same day emergency care services. There are several such same day emergency cares in our hospital. For example, we have a medical same day emergency care, a surgical one, a pediatric one, and a gynecological same day emergency care. So any patients presenting with these problems are directly sent to streamed directly to the same day emergency cares, and that in a way decreases the number of patients in the A&E department. And they can be directly managed by the right people, the specialists who are dealing with these problems day in and day out. There are many other things for which patients are. Output of the A&E department, we can improve the output of the A&E department because, like I said, all the walking well patients can be sent to the same day emergency cares and ambulatory care units. There are many patients who are admitted into the hospital because they need IV antibiotics in the veins. By IV, I mean antibiotics in the veins, because the oral antibiotics or the tablets that they're taking aren't working well. So they might need more specialized antibiotic directly into the vein so that they get a better outcome. But all these patients don't need to actually be in the hospital. There are several ways in which we can give antibiotics. The patient can come back every day to the areas in the hospital, like same day emergency cares, or they can be managed in the community. So having this better cohesion and communication between the primary care and the secondary care can help in preventing such patients taking a place in the hospitals. There can be many recall clinics which we can be set up, and that can direct the patients presenting with, say, ENT problems. It's a very highly specific problem. They can be sent to the ENT clinics. Not all these ENT clinics are emergencies. Same thing about the eye patients. If they are emergencies, they can be seen the following day. We also send patients, sometimes we send patients to plastic surgeons or burns unit. All these patients can be followed up in specific clinics. Not everybody needs to be in the emergency department. So better awareness, better communication, and better coordination in between the various primary care, secondary care, intermediate care. All this can go a long way in reducing the crowding in the A&E departments. I think just these simple basic things, if you tell in an MMI, I think you will score a lot of points.
Okay. Thank you very much, Lata. We all heard from the horse's mouth. They say, Dr. Lata, actually, she is speaking to us during a break from her shift today. And she was not supposed to work today, but she, as we all know, there is a junior doctor strikes, and Dr. Lata has kindly, for the patient concerned, she has agreed to do a shift. And then also, since she was really committed, she came over to speak to us. Thank you very much, and hope the rest of your shift is quiet, Lata. Thanks
Okay.
for
Thank you.
sparing your time. So we next have our final speakers. Many of you medical students hopefully would become medical students next year, and we have Saharsh and Edwin, who have kindly compiled a hot topics book, which we will be sharing with you within the next 10 days. So we will email you the e-copy of the book in 10 days time for all the students to have a look at it before your interviews. And they are going to share with us today how they prepared for their hot topics last year. You know, they are all currently year one medical students, and then they are going to share their experience. Over to you, Saharsh and Edwin.
Right, so quick intro from both of us. My name's Edwin. I'm a first year medical student at Leeds. And yeah, I am one of the co-authors of this Hot Topics book.
Yeah, hi everybody. I'm Saharsh. I'm one of the first year medical students at Aberdeen. And yeah, I'm also one of the co-authors on this book.
So yeah, me and Saharsh have actually been friends since high school. So working alongside him on this project is actually quite a good experience. We've been working on it for like the past few weeks now. And between us, we've covered about 13 of the hot topics that are quite relevant in medicine at the moment. This is something that obviously is very good for sort of medical school applicants like yourselves, but also it's something that you can keep an eye on going into medical school as well, because a lot of these issues will have more to them. There'll be different developments and things will change. So it really just sets you up for interviews, but then also further on at medical school as well. And yeah, we just hope it can be useful for you guys.
Okay. Any final tips on how you want students to prepare for the hot topics?
So the best things I'd say for when you're preparing for hot topics are use the book, use the health section of the BBC News BBC News website, and don't read the hot topics. Get a good idea of what the hot topics are. But when it comes to the interview practice, don't know them in and out. Don't try and say all the facts and the figures. And it's not a test of your knowledge. It's a test of can you discuss a complex health topic at a higher level, and that's the important thing about hot topics. So try and use these resources to try and get good understanding and how am I going to discuss this at interview? How am I going to be able to have a conversation with the interviewer? And that's the main, the importance of this hot topics book and just the knowledge of hot topics overall. And a few last minute tips for you guys. It's a conversation. It's not an interrogation. Just treat it like one and be relaxed when talking about this topic with the doctors at the interview.
Okay, a few questions from the chat box. I mean, if you have any questions, please post it now. We'll be finishing our session in 5 minutes time. What's the difference between secondary care and tertiary care? Dr. Senthil Kumar, do you wanted to answer that? Do you want to come on video?
Thank you. I was just posting it. So there are 4 levels of care actually. So the primary care is where you go and see your GP, the GP surgery. Secondary care is more related to the community services like community pediatrician or community mental health services. Tertiary care is when the patient gets hospitalized, like in the inpatient wards in the mental health or hospital. But also sometimes quaternary care is like in mental health. Following a patient of inpatient hospitalization, they may spend a time a year in rehab and recovery, whether it's for substance misuse or mental health. So there are 4 levels of care. Depends on the severity and intensity of the condition.
Okay, thank you, sir. And the next question, how do you talk about articles from BBC Health within your answers in an MMI? Saharsh or Edwin?
Yes, for that one.
Edwin, you go.
So for that one, I think don't try and memorize too much. Yeah. So when you're trying to memorize statistics, sometimes it can get a bit overwhelming. So maybe just think about general things that they mentioned in that article, general studies that they've sort of undergone within that article, and try to tie that in with your answer. But it doesn't have to be something that you force into the answer. It should just sort of flow naturally within it.
Okay, thank you very much then. So I know we are just running 10 minutes late. one final question. How do you tackle ethics question in the MMI? For example, the rejection of a vaccine. Senthil, do you want to answer?
Yeah. See, when it comes to ethics question, there is no right or wrong answer. How you balance the answer is very, very important. So you talk about the pros, you talk about the cons, and on balance, you say that because you can't compel everyone to have a vaccine. Like in the one other presentation, like before, you can't mandate it. So ethics is to see how's your level of. So, for example, in mental health, when patient is at risk, we try to offer them admission, and then when they say no, we don't automatically go for so mental health act assessment gives the power to the psychiatrist where we can admit them against their will. But we don't use this for every patient who refuses admission. Then you look at the level of risk, what's the level of community support. I'm just talking from a psychiatric perspective. So this is the basis for all ethics questions. There's no right or wrong answer. How you address the scenario. And also remember, these consultants who are the examiners have been dealing with this for years and years, and you're coming for the first time. As long as you don't talk any biased view or raise any red flags, it's perfectly fine. And as an examiner, we also know that you'll be anxious and various other factors. So do your best, and that's the important thing. So yeah.
And probably you might not need to come to a conclusion after ethics. You are just, people are looking at whether you can come to a balanced judgment. Sometimes you don't need to come to a judgment. You can even leave things as they are. Okay, thank you, Senthil. And thanks everyone. Hope your last hour was helpful. Please don't worry if it's too much of information. We just wanted to give you an idea, and nobody's expected to know everything. And also, we will send you the recording of this by next weekend, and the book will be sent to you within 10 days. I know it's a long day, we've got a busy week ahead. Over to you, Priya, to thank everyone before we finish.
Thanks, Dr. Anand. As you've said, it's been a long day, so I'm going to keep this short and sweet. So, hi everyone, I'm Priya. I'm the operations manager and also a second year psychology student here in Birmingham. I want to extend a very big thank you to all of our speakers today. So that's Edwin, Saharsh, Dr. Raji Anand, Dr. Senthil Kumar Mahalingam, Professor Reggie Alexander, Dr. Venkatesh, Dr. Hema, and finally Dr. Lada for taking the time in speaking on the variety of different topics that we've covered today. We all hope this has been very, very informative for everyone. Other than that, have a nice evening, and we'll see you all at our next event. Thank you, everyone.
Recording stopped.